Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Roche.
This program is presented by Medscape Education Global.
Hello, I'm Margaret Cheng. I'm a retina specialist based in Sacramento, California, and I'm delighted to welcome you to this program, Beyond Intervals, the next era of continuous delivery in retinal medicine. I'm delighted to be joined today by two fantastic retinal surgeons, Andrew Chang, based in Sydney, Australia.
Thanks very much, Margaret.
And Santiago Abengoechea, who is joining us remotely from Barcelona, Spain.
Hi, Margaret. How are you doing?
We're going to explain why continuous delivery of therapies can be life-changing for some patients, explain what's available now and what's coming in the future to enable this, and we'll give our own insight into the efficacy and the safety of these technologies and some practical tips. Andrew, you wanted to start by reminding our viewers about some of the retinal diseases that we're going to be talking about today.
That's right, Margaret. So neovascular macular degeneration and diabetic macular edema are chronic diseases that affect our patients. They affect both eyes, and their disease progression is for years. And the clinical course that challenges us as clinicians is that it is unpredictable. And the lack of control, if we can't achieve that, will lead to inevitable vision loss, not just in one eye, but also the other eye. And in the real world, this impact influences an ability to remain independent, to read, to drive. And in our diabetic populations, they are in the working population too. And many of our patients have comorbidities, both with wet AMD as well as diabetic macular edema. So it's so critical that we control these chronic diseases to maintain sight.
Absolutely. I think in the last 20 years, we've really had a revolution in terms of how we can treat these chronic problems. So, I remember when laser therapy was really the only option. But since then, we've had these amazing new anti-VEGF therapies that have been shown in clinical trials and clinical practice to do very well for these patients. But I do think there's still a huge treatment burden. These medications wear off over time, and it requires a lot of commitment from the patients and from the families to keep on coming in for repeated treatments. And we can see that in the real world, those visual acuity results are just not mirrored as they are in clinical practice. And so because of this, I think that there's a real need for sustained delivery, better efficacious medications that can last longer so that the visual acuity of our patients and their quality of life can be improved. So, Andrew, what would your dream treatment for neovascular AMD and DME be like?
Well, I think you've touched on that, Margaret. These patients have a burden not only of visits, but also of interventions. So to reduce these burdens, to give more certainty and control over disease activity, so that is to eliminate fluid fluctuations and their peaks and troughs, because we know that can ultimately affect the sight. And for us in our clinic, to reduce the burden, to give predictability for how we might schedule patients in our clinics, and that has an impact also on family. And the concept of equitable access is important. By that, I mean patients have to travel in to have their treatment. So if there are ways in which we can control this, that would be a dream, not only for us as doctors and also for patients.
Those are really great points. And sometimes we really do forget how these injections affect our patients. And so let's hear now from one of our patients who's had these issues.
I have macular degeneration. One eye is dry MD and the other is wet MD. I was diagnosed about 2 years ago, 2.5 years ago, by my optometrist, and he's very concerned and sent me to retinal consultants the very next day. They started giving me the eye shots right away, and I had to have them every single month for about over a little over a year. I don't know if I could say they were happy with the results because he was seeing damage to my eye from constantly having to have the shots. As much as I appreciated the fact that they were helping me to keep my sight, it was a very difficult time asking someone for a ride every single month. It was painful and it took up a lot of time. Sometimes you'd sit in the waiting room for 45 minutes. Um, so it was a important but difficult process for me. And the doctor was concerned about as many shots as I was needing into my eye. And that's when he suggested the surgery to me.
So, as you can see, our patients do have issues with finding transportation. Their caregivers are often stressed by their frequent appointments, and they still become very anxious about these appointments and about the injections, even if they've had these injections long term. They often have to set aside the entire day in order to come to our appointments, and oftentimes my patients will tell me that they have to take a nap afterwards, and they're pretty much not able to function for the rest of the day after an injection just because the whole day has been so tiring. So, Santiago, continuous delivery of therapeutic agents is something that we've aspired to for a while, but can you tell us why this is needed in a little bit more detail?
Yeah, definitely. Actually, the intravitreal injections work very well in most of our patients. They're highly effective, but treatment burden, as you just said, is very high. If you just take a look at the retrospective analysis from the Retinal Blindness Registry, we see that 25% of our patients require intravitreal injections every 6 weeks or less at 2 years. If we also know that 40% of those patients discontinue their treatment within these 2 years. And on the other hand, we know that the higher CST variability associates with lower VCVA gains. If we take a look at the analysis combined brolucizumab and aflibercept data from Hawk and Harrier trials, we know if we divide it in these four quartiles, we know the fourth quartile that has more fluid, or the CST is higher. Those patients have less visual acuity gains.
Thank you, Santiago. And can you tell us a little bit about what's in development to achieve this continuous delivery?
Yeah, the treatment landscape is moving towards therapies with increased durability and freedom from frequent injections. In future, we're going to have these tyrosine kinase inhibitors. The treatment interval would be around 6 months, but we see those patients with this supplemental treatment before 6 months. It's between 25 and 35% of those patients. You were talking about the gene therapies. The treatment interval will be around 3 years, which is a very good result. But those they need supplemental treatment before those 6 months, between 25 and 50% of the patients. On the other hand, we have the port delivery system with ranibizumab. It's an implantation in the operating room. We have to refill it every 6 months in the clinic. And actually, it's in the FDA, it's approved for diabetic macular edema and also for neovascular AMD and diabetic retinopathy. It's been studied for over 10 years. It suppresses constantly the VGF, so that means that the patient remains drier and stable during time. Actually, I'm involved in a clinical trial, which is called a Velodome clinical trial that I have 2 arms, 6 months and 9 months. We know that the continuous delivery achieves a smooth pharmacokinetics profile of drug concentration in vitreous. That means that the more suppressed is the VGF, the constant will be the effect of it. On the other hand, with our intravitreal injections, mainly the first generation of them, we have these saw teeth that it's increasing and decreasing this suppression of the VGF. Recently has been manufacturing improvements to reduce the risk, to avoid actually the risk of having a septum dislodgement. They have changed the septum. It's the needle is lightly lubricated, so that means the refills are safer for the patient. As I just said before, we need an implantation in the OR. We have to follow. I don't think it's a very difficult surgery. I think it's quite simple surgery, but it has lots of details. Margaret, I have experience in clinical trials, as I just told you before, but I don't have experience in the clinical practice, in the real world. What's your experience with the PDS nowadays?
Well, I've been using PDS since the original phase 2 ladder trials way back. And all of these patients did get rolled over from ladder and archway into the portal extension study. And now with FDA approval of the PDS for neovascular AMD, DME, and DR, I've been implanting it commercially as well. Even patients who have to come in monthly for these clinical trial visits prefer the PDS, not because there's a decreased visit load, which there is out in the real world, but because there's less anxiety about each visit. They don't have to have as many procedures. The refill is generally more comfortable for them than the injections. So actually, I would say the first few cases that I've done commercially were fellow eyes of patients who were in clinical trials because they saw how well their clinical trial eye was doing and they wanted the same for their fellow eye. So that's been really amazing. That's happened in both AMD and DME patients. And the other thing I'd say about DME and the PDS is that there's actual regression of the diabetic retinopathy that is quite marked. We can really see that the DRSS stage of the treated PDS eye is much improved. And oftentimes we'll see in the fellow eye that there's progression to proliferative disease or worsening DME. And so those patients are also very enthusiastic about going forward with the PDS. Long-term, these patients do great. I've got a couple patients rolled over again from ladder. They've had PDS in for 10 years, still 2025. So really amazing real-world experience that really does correlate with clinical trial data. And it does also align with the published 3-year world data. So, the SUMMIT study, which was a real-world study spearheaded by Arshad Kanani, looked at 83 eyes and 83 patients, followed them over 3 years. And he found with his co-authors that the visual acuity, again, is stable in these real-world patients. The CST is stable. And even though these patients had pretty high needs in terms of anti-VEGF before PDS implantation, so they needed a mean of 9 injections before PDS implantation, they were able to go pretty much out to almost 8 months between refills. So, in our clinical trials in the US, we refilled neovascular AMD every 6 months. But in the real world, we're seeing that there's some flexibility in this. And that's something that I've also experienced as well with my real world clinical experience with PDS. They found in this study that there were no cases of endophthalmitis and there was no conjunctival retraction. There are more AEs associated with the PDS, of course, than intravitreal injections, which is only natural since it is a surgery. But we'll talk a little bit more about surgical technique and what we need to do in order to decrease the surgical complications later on. Do you have anything to add, Andrew?
We also have patients in the velodrome study. And what I've noticed is that as we follow the patients on the trial, a small amount of fluid develops, not a lot, away from the center, and it's not affecting sight. But on the next visit, it disappears. So really, I think what is happening biologically is that there is a tendency to develop more activity and exudation. But because we've got a continuous supply of anti-VEGF drug, that keeps it suppressed. So I can imagine if these patients weren't having a continuous supply of drug to suppress the exudation, that they may then have lost vision, and then they would require further injections. So this is really a very proactive way of controlling disease activity. And so I think this fluctuation, and we know this, is not good for photoreceptors and development later of atrophy and fibrosis. And we also found that rescue injections were rarely required. But Margaret, it's a surgical procedure, and it involves not only implanting the device, but also refill. And you've had very vast experience both in clinical trials and now in the real world. What would you say to safety if we have a patient in front of us?
Well, I think we have to choose our patients carefully. So patients who have healthy conjunctiva are obviously going to be best because ultimately when we're talking about long-term safety, having good conjunctiva tenons over that implant is going to decrease that risk of erosions later on. And if we can decrease the risk of conjunctival complications, that actually leads to decreased incidence of endophthalmitis, which is what we don't want at all. The other thing is to realize that the refill procedure is not an intravitreal injection. It is something that can be easily learned. There is a stepwise process to it, but you have to make sure that you're perpendicular to that implant before you go in with the refill needle. And that's really going to decrease the number of punctures of that conjunctiva when you're doing a refill exchange, because that's another safety point that could be an issue if you have problems with the refill exchange and you traumatize the conjunctiva a lot. That could lead to an increased risk of endophthalmitis with a refill exchange. But again, I think, as Santiago pointed out, this is not a complicated procedure. And it's not a complicated refill procedure, but there are certain steps that need to be followed, and each step really builds on the next one for the ultimate success.
Yeah, I agree completely. I think the patient selection is one of the keys, or the key points I had of these patients that I on surgery. Actually, the first one, she had a very, very thin conjunctiva and tendon. We have to think there are patients that they can be they are elderly patients, so we have to choose which conjunctiva and tendon are good for maintaining stable this device under them. I think it's very important the opening and the closure of the conjunctiva. The best we make the opening of the conjunctiva, the better closure we're going to have, and we're going to avoid this conjunctiva retraction in the future. And that's one of the main causes of this endophthalmitis. Margaret, you were talking about the refills. I want to know what's your experience with them. How often are you doing them? How are they, and who actually does them in your clinic?
Thanks, Santiago. Yeah, the refill exchange, again, when I first started out, I'd block off my entire lunch hour because I wanted to make sure that it would be smooth and that I didn't feel stressed about it. But now, the refills just show up in my clinic. And honestly, we've had to, film these for clinical trials. And you can see from start to finish, from when I put on my sterile gloves to the very end, it's less than a minute and a half. Um, Again, it is something that, I'm used to at this point because it's something stepwise. I, make sure that I set myself up with a sterile field. All of these instruments we actually put in a bag together so that we're not searching all over the clinic for them. And then you really have to position the patient well. I've found that, making sure the patient is laid all the way back so that I can really see whether they're perpendicular really makes it much, much easier. And this newer needle that was just introduced that's lubricated with a very small amount of silicone has made all the difference. So the amount of force necessary to puncture the septum in order to do the refill exchange has gone down in trials by half. I'd say it's more than that. It really goes in very, very smoothly. And that makes it much easier, not only for me, but also for the patient. It's a lot more comfortable for them. In terms of timing, we were talking about real world data, in the summit study where they were going out to 8 months. I'd say that I probably start with 6 months when it's the first refill exchange, just because I like to make sure that the patient is well controlled with the PDS, especially since I'm usually implanting them in patients who've needed a lot of injections in the past. And if they're doing well after 6 months, then there is some flexibility to that. The longest I've gone in between refill exchanges in clinical practice is about a year. So, Andrew, a big part of new technologies is to understand who the right patients are for these extended therapies. And what do we know about that?
I think you've touched on this together with Santiago. But I think if we go back, just explaining to a patient that it is a surgical procedure, it's now quite well defined. We have guidelines that enable us to perform the procedure carefully, reducing the risks as well. And we've touched on conjunctival health, and that is a conjunctiva scarred from any previous surgery? It may be also useful, and we did this in the trial, to check the mobility and thickness just with a cotton bud, to take a history because there are some glaucoma medications that can cause inflammation and scarring. But another important aspect is that this is a conversation you have with a patient. And it's important to explain the burden of treatment and versus a initial surgical procedure. But the treatment refill of 6 or 9 months is really a game changer for these patients. And certainly with patients that are on the trial, they really are very positive about it. And as you've indicated, the refill was initially a little challenging because the needle needed a little more pressure to enter the septum, but the newer needle is quite effortless.
Absolutely. Well, those are all good points, and we'll take it back to our patient who's going to tell us about their experience with the port delivery system.
I was very grateful when they came up with the surgery. It was explained that it would be an implant that was put into my eye and that it would only require being refilled once every 6 months. The surgery itself was so easy. The hard part was I had to drive 2 hours away and stay overnight, so I had to make those arrangements. But the surgery itself, I went in the morning and I was awake during the surgery. There was absolutely no pain. and I needed to go back the next morning to be checked out. Everything was fine. The light hurt my eyes, the sun, driving home, but by the time I got home, I was absolutely fine. There was nothing. I had no, like, recovery time after the surgery. And then, it was just every 6 months going in to, have the refill, and the refill was so much easier than the shots themselves. I expected because it was an implant, this was gonna be a big deal. It wasn't. It was much easier than the shots themselves. Since the surgery, it's been wonderful. It isn't waiting every month for the shots, looking for rides, and like I said, it was more painful. So, now it's very pleasant, and once every 6 months to have an appointment is nothing. So, made life much easier for me.
So we're hearing from the patient that, they really love not having to come in all the time for these injections. We hear over and over about the treatment burden, the visit burden, and not having to worry so much about having an injection. I've had patients, other than this one, who have told me that they are kind of nervous all night, the night before a clinic visit, just because they're worried about the injection, even though the injection itself is not painful. So, this all aligns with clinical trial data. As I talked about previously, the patient preference for the PDS is quite remarkable. In the DME studies and in the neovascular AMD studies, patient preference for the PDS was overwhelming. And even patients who crossed over from the intravitreal arm to the PDS also overwhelmingly preferred the PDS for fewer injections and less anxiety. And I think we often think that over time patients get used to it. So more injections, if they've had injections for a couple of years, they're probably not as anxious. But we can see from this preference data, I think that patients really do feel anxiety about intravitreal injections. So I'd like to open this up to, you, Andrew, and Santiago. What do you guys think is coming in continuous delivery?
This is a long-term delivery device. And so when I'm explaining this to patients, I'll say, well, later you may require other intraocular procedures, and that would include cataract surgery, glaucoma surgery, and Margaret, we can hear from you in the real world. Does that impact on care and the function of the device? My understanding, it isn't. And also, this is changing potentially the workflow for our clinics and the teams we work in. For instance, now with 6 to 9 months refill, and for patients that don't need to come to our practices as much, then they can be followed locally, particularly if they live in remote areas. So you can imagine if we have a diabetic that lives quite far away and they have to travel in, and as you've touched on, it's at least a day or 2 days to recover and to travel in. This is going to be much, much easier for that patient. And you've touched on another area too, and that's patient anxiety. Patients are anxious not really, I think, because of the injection itself, which you've said, but I think the unpredictability. So we do treat and extend to try to bring a predictable path in the clinic. But in the future, with long-term delivery devices, this is going to be much easier to manage.
Santiago, what do you think about the monitoring of these patients that's necessary? We always um, talk about these extended duration therapies, maybe 6 to 9 months. But what do you foresee as being a monitoring scenario in your practice?
I think actually they treat and extend in different ways, but I think will be our our best way to follow our patients anyway. Even if we have long-standing therapies, like it be PDS, we have to monitor those patients and try not to be inactive neovascular membranes. As we're doing now with our patients, you can have the PDS that last 6 months, even it's dry, you can do it, refill it again, and maybe you can control that patient in 7 months, and then it could be like 8 months. That's what I think is going to be the future. Uh, we also have to know how to learn how to fit the actual intravitreal injections with those devices. In some cases, we have to use them as a rescue tool. So I think we don't have to miss the intravitreal injections that we have nowadays, but we have to combine them with the new therapies that will be for sure much better, that will long more time, and that will be a very good benefit for our patients. But we have to change our mind. I mean, we have to establish how to monitor those patients, how to establish these workflows again. I think we're all learning, and in the future, in the near future, hopefully, we'll manage much better our patients for sure.
Excellent. Well, I think we've learned today that neovascular AMD and DME are chronic diseases. They are important things that we need to try to treat with longer duration intervals because of patient preferences for fewer therapies, extended duration, better durability, and better efficacy. The PDS with ranibizumab is FDA approved already in the United States for diabetic retinopathy, DME, and neovascular AMD, and can be an important tool in our armamentarium for these patients. But there are also other therapies down the pipeline, such as TKIs and gene therapy, that may also be useful tools, as well as adjuncts to intravitreal anti-VEGF therapies. Thank you, Andrew and Santiago, for this great discussion today. And thank you for your attention. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.